Welcome to this section. We shall be discussing anemia in pregnancy. I'm Dr. Anaemia Joseph, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University Teaching Hospital Complex, Ile-Ife. Anemia in pregnancy is one of the diseases of the importance of public health importance, and it affects both the developing and the developed countries. At the end of this lecture, you should be able to define anemia in pregnancy, to be able to describe the etiologies of anemia in pregnancy, to know the various types of anemia in pregnancy, to make a list of various complications of anemia in pregnancy, to be familiar with range of steps in the treatment of anemia in pregnancy, and to set guidelines for prevention of anemia in pregnancy. By way of introduction, anemia is said to occur when there is a reduction below normal of the total circulating hemoglobin mass for age and sex, with a subsequent reduction in oxygen carrying capacity of the blood. And it is one of the common disorders affecting women in the world today. Anemia in pregnancy is a direct and indirect cause of maternal and perinatal mortality, and antenatal care should be concerned with early detection and management of all degrees of anemia in pregnancy. It is still a problem in the developing and developed countries. Anemia in pregnancy has been defined by World Health Organization as a condition of low circulating hemoglobin in which the hemoglobin concentration has fallen below a threshold, lying at 2 standard deviations below the median of a healthy population of the same age, sex, and stage of pregnancies. It can also be defined as hemoglobin concentration of less than 11 grams per dl and a hematocrit of less than 33%. And the Center for Disease Control in the United States of America has proposed a cutoff point of 10.5 grams per dl during the second trimester. Each year, more than 500,000 of women die of pregnancy-related causes, the vast majority, about 99%, occurring in the developing countries. And anemia in combination with obstetric hemorrhage has contributed about 17 to 46% of maternal deaths. Conservative estimates indicate that 1.5 million people are anemic worldwide, with the majority, about 1.4 million, in the developing world, mainly in the Southern Asia and Africa. Estimates of maternal mortality from anemia ranges from 34 per 100 live births in Nigeria, and it's as high as 194 per 100,000 in Pakistan. 40% of the world population are suffering from anemia in pregnancy, with about 35% of anemia in the non-pregnant women, and 55% of anemia in pregnancy in pregnant women, and about 3 to 4% times higher in the developing than in the developed countries. Why is anemia common in pregnancy? Anemia is common in pregnancy because of the physiological changes that occurs in pregnancy. In pregnancy, plasma volume expands by 46 to 55%, while the red cell mass expands by 18 to 25%, both these contributing to physiological hemodilution, which occur particularly in the second trimesters of pregnancy. Also, increase in demands for nutrients and hemopoietic factors. For example, during pregnancy, there is increase in demand by the fetus, by the placenta during the lactation, and increase in the body weight gain during pregnancy. This has contributed to the increased demand in pregnancy, thereby contributing to anemia in pregnancy. Also, there is increased susceptibility to malaria because of altered immunity, especially in the nulliparous women. So this increase in susceptibility to malaria can predispose them to have malaria in pregnancy. Also, decrease or short interpregnancy interval has been known to contribute to anemia in pregnancy, and this is commoner in the teenagers, in the grand multiparous women, and also in multiple pregnancy. Also, failure or inadequate intake of hematinics, which can be either from the food or by medication during pregnancy, has also increased the risk of having anemia in pregnancy. And early in pregnancy, there can be nausea and vomiting, which can contribute to failure or inadequate intake of these hematinics during pregnancy. How can we classify anemia in pregnancy? It can be classified, one, based on the packed cell volume, and we have mild, moderate, severe, and very severe or critical. When the packed cell volume ranges between 27 to 29%, it is regarded as mild anemia. When it ranges between 19 to 26%, it's regarded as moderate anemia. And when it ranges less than 19%, it's regarded as severe anemia. And when it is less than 14%, it is very severe or critical anemia. Also, it can be classified based on the morphology, and this is based on the red blood cell size and the hemoglobin content of the red blood cell. And under this, it can be described as being normochromic, normocytic, hypochromic, microcytic, macrocytic anemia, megaloblastic anemia, and dimorphic anemia. Also, what are the etiological causes of anemia? It could be from decreased red cell production, and this could result from nutritional anemia, which is the commonest cause of anemia in this environment. And this nutritional anemia could be from iron deficiency and folate deficiency. Could also be from bone marrow failure, in which aplastic anemia and pure red cell aplasia will be responsible for. And if there is associated systemic disease like chronic renal failure, tuberculosis could present as anemia in pregnancy. And if there is bone marrow infiltration by a neoplasia, could also be a cause of anemia in pregnancy. Also, when there is increased red cell destruction, otherwise known as hemolytic anemia, and this could result from intrinsic abnormality, and this can be seen in patients that have hemoglobinopathies, for example, sickle cell anemia disease patient or thalassemia. And when there are membrane disorders of the red blood cell resulting from erythrocytosis and spherocytosis, and when there are enzyme deficiency, as could be seen in patients with glucose 6-phosphate dehydrogenase deficiency and pyruvate kinase deficiency, they could present as enzyme deficiency, leading to anemia in pregnancy. Also, there are some extrinsic abnormality that could affect the red blood cell, thereby leading to anemia in pregnancy, and this includes infections with malaria. When there is septicemia, could be antibody-mediated destructions. When there are hypersplenism, or when there is immune hemolytic anemia, or when we have mechanical destructions. Also, when there are increased red cell loss, and this could occur when we have acute or chronic blood loss. Acute blood loss secondary to abortions, ectopic pregnancy, antepartum hemorrhage, and postpartum hemorrhage, and chronic chronic red cell loss, which will occur as a result of hookworm infestation, hemorrhoids, peptic ulcer disease, and schistosomiasis. What are the common causes of anemia in pregnancy in the developing countries in this environment? From the aforementioned risk factors that I've talked about, nutritional deficiency, which is the commonest, and this includes the folic acid and iron deficiency anemia, otherwise known as the dimorphic anemia, which I will still dilate on. Malaria in pregnancy, parasitemia in infestation from hookworm, hemoglobinopathies, acute blood loss, hookworm infestation, HIV, and AIDS. They constitute the common causes of anemia in pregnancy in this environment. The etiology of anemia in pregnancy in developing countries is probably multifactorial. The different causes interact to form a complex picture. For example, hemolysis as a result of malaria in pregnancy could result in folate deficiency and associated splenomegaly, which may result in sequestration with further destruction of red blood cells. Then the relative contribution of each of these etiological factors will vary from geographical area and by a season. Iron deficiency anemia is the commonest type of anemia in pregnancy worldwide. And iron imbalance in a healthy state involves regulation between the intake and loss of iron. And iron can be lost from the intestinal mucosa through lactation and during breastfeeding, through the skin during menstruation, and absorption of iron could also be true when a patient has iron deficiency, in which 50% will be absorbed, then 50 to 30% during normal iron balance, and 5 to 8% in excessive iron diet can be absorbed. Then iron requirement in pregnancy vary with maternal weight, the size of the fetus, then the number of fetuses the patient is carrying, and it has been found out that each fetus will require 500 grams of iron, and also the maturity of the fetus. While early in pregnancy, one requires 2.5 milligrams per day of iron, and during the second trimester, between 20 and 32 weeks, 5.5 milligrams per day of iron is required by a pregnant woman, while after 32 weeks of gestation, 6 to 8 milligrams per day of iron is needed by a pregnant woman. Then their iron in pregnancy, during pregnancy, it has been found out that the iron is being acquired, and iron is needed in various ways. For example, a basal iron loss, about 280 milligrams of iron is being lost, while for expansion of red blood cell mass, about 570 milligrams of iron is needed to acquire this. And the fetus needs about 200 to 350 milligrams of iron to be able to grow very well. And placenta will acquire about 50 to 150 milligrams of iron during pregnancy, while blood loss at delivery constitute about 100 to 250 milligrams of iron during pregnancy. And iron is conserved by amenorrhea, and about 240 to 480 milligrams of iron is being conserved during amenorrhea. And an average diet will contain about 6 milligrams of iron per 1,000 calories, and about 10% of dietary iron is being absorbed. What are the sources of iron? The sources could be divided into heme and non-immune source. And from the non-heme source, this includes from the cereal, from the vegetable, from the seeds, milk, and egg. While from the heme source includes from the animal flesh, from the animal blood, and also from viscera like the liver and the kidney. What are the causes of high prevalence of iron deficiency anemia in her environment? Because of the poor diet, most of our patients are from the low socioeconomic status, and because of this, they are not taking adequate diets. They have poor diet. Also, poor dietary habits and decreased absorption, probably from worm infestation, tropical sprue, HIV enteropathy. And also their depletion of iron, which could be from multiple pregnancy, from decreased interval between pregnancy, and when there are excessive loss at delivery, and also from GIT blood loss, which could result from hemorrhoids, chronic duodenal ulcer, and from amebiasis. From diet, also we could have the absorption of iron, and from diet there could be various amounts of iron that could be absorbed. And this will from low bioavailability diet, from intermediate bioavailability diet, and high bioavailability diet. Diets that are of low bioavailability diet, they are prevalent in the developing countries, and these will account for absorption of as low as 3 to 4%. An example of this diet include from the cereals, from the rice, and from the maize. While diets that are high of bioavailability, they are found in developed countries, and they tend to vary in diet that are rich in meat, poultry, and fish. Also, dietary habits have been found to influence iron absorption. For example, the vegetarians, also food taboos. Some people has some food taboo, and from the custom and rituals. Some people don't take snails. Also, there are some people that are affected by pica from food of little or no dietary value, and also from cooking habits can also lead to anemia in pregnancy from the way the food is being processed. What are the enhancer of absorption of iron, and what are the inhibitors? What are the factors that will lead to increase in iron absorption, and what are the factors that will inhibit iron absorption? Ascorbic acid, gastric acidity, protein, alcohol has been known to enhance iron absorption, while phytates, tannins, tea and coffee, and calcium, herbal drinks, and polyphenols has been known to be the inhibitor of iron absorption. Also, folate and B2 deficiency has been found to be one of the causes of anemia in pregnancy in this environment, and about 50 to 100 micrograms of folic acid is required daily for a pregnant woman, and the body store is about 5 to 10 milligram, and the depletion is rapid, about 4 months for it to get depleted in the body. And the source of folic acid include green vegetable from the fruits, from the liver, and from the kidney. And it has been found that folic acid, they are easily destroyed. So people that cooked food to excess can actually have their folic acid being destroyed in the food. And also, absorption is from the duodenum and jejunum. And this is different from vitamin B12, in which about 3 to 5 microgram is being required daily, and the body store is about 3 to 5 milligram. And it will take about 3 to 5 years for depletion of vitamin B12 to occur. And it is the source of vitamin B12 includes from the meat or milk, from the fish, and from the eggs. And also, its liability has little effect on vitamin B12, and vitamin B12 is being absorbed from distal ileum. Folic acid also is one of the deficiency is one of the causes of anemia in pregnancy, and this could result from low intake, from anorexia, from nausea, from vomiting, and from malabsorption syndrome, and also from GIT diseases. Also, loss of folate as it occurs during pregnancy could also lead to deficiency of folic acid. Prolonged cooking, as is very common in the Yoruba and also in some parts of the Nigerians, could also lead to folic acid deficiency. And also, antifolate drugs like phenytoin, pyrimethamine, and trimethoprim could lead to folic acid deficiency. Vitamin B12 is also one of the causes of anemia in pregnancy if lacked, and this could result from low intake, as it can be seen from the vegetarians. Also, lack of intrinsic factor, which is a cofactor in the absorption of vitamin B12. Lack of this intrinsic factor could lead to vitamin B2 deficiency, leading to anemia in pregnancy. Also, some procedure like gastrectomy, which is a procedure that is being done. For example, if a patient has a gastric cancer, gastrectomy can be done, and also from other procedure which will reduce the size of the stomach, and this will lead to decreased absorption of vitamin A, B12, which can also be one of the cause. Also, from pernicious anemia could also be one of the causes of vitamin B12 deficiency. Intestinal losses, which could result from ileal disease, from where vitamin B12 is being absorbed, and also from ileal resection, could also be one of the causes of vitamin B12 deficiency. What are the effects of anemia in pregnancy on mother? And these could range from mental lassitude to diminished physical performance, to loss of home care and child care, to loss of working hours. They can be susceptible to infection. There can be heart decompensation and heart failure, and could also predispose to pre-eclampsia. There could be increased risk of thromboembolism, decompensation with cardiac or respiratory disease. They could come down with preterm labor and preterm delivery. There could be increased risk of severe consequences in the presence of antepartum hemorrhage and postpartum hemorrhage, which they can be predisposed to. And also, there's little blood loss at delivery, which may become life-threatening. There could be increased rate of operative deliveries. There could be aggravation of other complications of pregnancy. There could be increased maternal mortality, which could be 3 to 5 times higher. And there could be delayed physical recovery, especially after cesarean section, and in women of high parity and of low socioeconomic status. What are the effects of anemia in pregnancy on the fetus? There could be spontaneous abortion, early in gestation. There could be intrauterine growth restriction or low birth weight. There could be prematurity. There could be anemia in infancy, and they could also be complicated with abruptio placentae. There could be intrauterine fetal death, neural tube defect, especially when there's folate deficiency, increased stillbirth rate, increased prenatal and infant mortality and morbidity rates, increased risk of perinatal complications. There could be low iron stores in the fetus, neonatal parasitemia, anemia in infancy as a result of low iron store. There could be poor immunity, poor nutrition, increased risk of infections, delay in mental and psychomotor development. How do we manage a woman that has anemia in pregnancy? Management will range from diagnosis, which will be from good history, intake, examination of the woman, investigation before proceeding to treatment. Clinical features can be classified based on underlying causes of the anemia, though the classical symptoms presentation includes tiredness, weakness, dizziness, although this present in small percentage of patients. And the majority, over 80%, are picked up from the routine estimation of hematocrit level during the visit to the antenatal clinic. And in severe cases, there may be classical symptoms warranting admission, and this will include dyspnea and generalized edema. On general examination, there is pallor of mucous membrane, and this can be gotten from the examination of the tongue, from the buccal mucosa, and from the conjunctiva. The palms of the hand, fingernail beds, and sole of the feet are also to be examined for pallor, while jaundice may suggest an hemolytic cause, and a systemic examination should be done for further evaluation of the cause of the anemia. What are the principles of management of anemia? Identification of the cause is crucial for the management of anemia, and this can be gotten from a good history, clinical examination, and investigations. And correction of anemia by the most appropriate method depends on the severity of anemia, the gestational age at the time of diagnosis, and the objective is to correct the anemia before term or before the onset of labor. What are the investigations required for a woman with anemia in pregnancy? A full blood count and differentials with a reticulocyte count is going to be done for the patient, and a PCV, which could reflect the severity, the prognosis, and the outcome of this patient. Also, blood film, thick and thin blood film for malaria parasites is also necessary to know the one that has malaria in pregnancy and needs to be treated. Also, hemoglobin electrophoresis is also crucial in the management of patients with anemia in pregnancy, and from their sickle cell disease is going to be get. Also, blood group and resource factor, Coombs test, direct and indirect, red cell folate, serum vitamin B12, iron studies, which will include the serum iron, the total iron binding capacity, and the serum ferritin needs to be assayed for in a patient with anemia in pregnancy. Also, bone marrow aspiration, especially for patients that has bone marrow depression or some other myelosuppressive diseases. Also, blood film is also important, and this could be interpreted as being normochromic, normocytic, and this is seen in dilutional anemia. Also, microcytic, which would be normochromic, which can be microcytic hypochromic, as can be seen in iron deficiency anemia. Also, microcytic normocytic, which can be seen in worm infestation. Also, macrocytic fissures will be suggestive of vitamin B12, and also sickling is also a test which could be suggestive of hemoglobinopathies, especially sickle cell disease. And also others like megaloblastic can be seen in vitamin B12 deficiency, which is of a higher incidence in the strict vegetarian. Also, microbiological investigation is also important. Stool for microscopy is important in patients with hookworm infestation, in which one will look for ova of hookworm and worm load. Urine for microscopic culture and sensitivity. Sputum for microscopic culture and sensitivity, and acid-fast bacilli for patients that has Mycobacterium tuberculosis. Also, radiological investigation, chest X-ray could reveal chest investigation and signs of tuberculosis. And also, ultrasound is germane, which can be used to rule out a complication that could ensure from anemia in pregnancy. For example, intrauterine growth restriction could be picked from the ultrasound. Other investigation would include HIV screening, liver function tests. What are the principles of treatment? The principle of treatment of anemia in pregnancy will include to identify the cause of the anemia, to correct the anemia, and which will depend on the severity of the anemia and the gestational age at which the anemia is peaked. And we should know that anemia in pregnancy treatment may also be multidisciplinary in management. The objective of the treatment is to correct anemia before term and before the onset of labor. And the treatment of an undeterminable cause after investigation, any cause that is found, one will need to treat it. If the patient he has malaria, anti-malaria needs to be prescribed to treat the patient adequately. And also prophylaxis for malaria can also be given in the prevention of malaria in pregnancy. And this could be with the use of intermittent preventive therapy for malaria, which entails giving pyrimethamine and sulfadoxine for pregnant women from second trimester till delivery with the use of Fancida. And also, personal hygiene also is important in the management of patients with anemia in pregnancy. For patients that has urinary tract infection as the cause, antibiotics is going to be given to the patient. Patients that are presented with pyelonephritis with symptoms need to be treated with an appropriate antibiotics. And also, a patient that has tuberculosis, anti-tuberculous drug needs to be prescribed for the patient. For patients that has hookworm infestation as the cause of the anemia until emetic will be prescribed, and this, for example, albendazole, mebendazole needs to be prescribed for the patient. And also those that has their cause as a result of autoimmune hemolytic anemia could benefit from steroids. Correction of anemia, we can correct anemia with the use of hematinics, erythropoietin, and blood products. With the use of hematinics could be by oral or parenteral routes, which I will dilate more further. Before 37 weeks, mild anemia can be managed with oral hematinics, and this will involve the use of ferrous supplement thrice daily with an addition of folic acid. One can give ferrous 200 mg 3 times daily and folic acid 5 mg daily. And from 37 weeks till delivery, blood transfusion, especially packed cells, is encouraged to be given for patients that has mild anemia from term, 37 completed weeks till delivery. While for moderate anemia, management for patients from 32 to 34 weeks of gestation, oral hematinics can be used. However, after 32 weeks and above till delivery, blood transfusion should be offered this kind of patients. For severe anemia, blood transfusion, irrespective of gestational age, and packed cell is favored when there is no active bleeding, and the aim is to achieve hematocrit of 27% before 32 weeks of gestation and 30% and above by 36 weeks of gestation. There are various iron supplements, various iron preparation, and their iron content, and this includes ferrous sulfate, ferrous fumarate, and ferrous gluconate. The amount of elemental iron in ferrous sulfate is 60 milligram, and ferrous sulfate can be given 200 milligram thrice daily. For ferrous fumarate, 200 milligram 3 times daily can be given, and the elemental iron content is 66 milligram per tablet. While for ferrous gluconate, 300 milligram 3 times daily can be given, and it has 36 milligram per tablet of ferrous gluconate. And what are the things to note during iron supplementation? We should note that all the supplementation has similar efficacy, irrespective of formulation and route by which we are giving the patient, and they will increase hemoglobin by 0.3 to 1 gram per dl per week, and the response to therapy is usually between 5 to 10 days, which will be seen from the reticulocyte count done after the administration of iron. And a minimum of 180 milligram of elemental iron is needed daily for a pregnant woman, while folic acid and vitamin C therapy potentiates the effects of iron. What are the drawbacks of oral formulation of iron? And this could result from intolerance of medication, longer duration of action, then compliance challenges. Some patients are not compliant, thereby they will not take the iron supplementation adequately. What are the side effects of iron supplementation? Nausea, vomiting, abdominal cramps, constipation, diarrhea. Why? How do we manage the side effects? One can stop or reduce the dosage of iron. Then one can use the iron drugs with meal, and one can change to another formulation. And for the parenteral iron formulation, there are different types that can be used: iron dextran, iron sorbitol, and iron dextran, the trade name Imferon, iron sorbitol, Jectofar, and there is also Jectofar Plus. What are the indications for parenteral iron? Patients that are non-compliant with oral formulation, intolerable side effects of oral formulation, malabsorption syndrome, and severe iron deficiency anemia. All these could be an indication for parenteral iron. Methods of administration of iron. When giving less than 2,500 milligram, one needs to give all the iron. If it's less than 2,500 milligram, one is given. However, if the dosage is more than 2,500 milligram, one needs to give it in 2 divided dosages. And also to give the iron dextran intravenously, a test dose needs to be given slowly before giving the rest 1 to 2 hours after. And for iron sorbitol, which is given intramuscularly, a test dose of 50 milligram needs to be given first, followed by 100 milligram daily dose in alternate buttocks. What are the formula used in calculation of iron supplementation? For iron dextran, one needs to calculate the deficit, and this will be by subtracting the normal hemoglobin concentration from the patient hemoglobin, multiplied by the patient's body weight, and multiplied by 2.21 with plus 1,000 milligram, or one could replace 250 milligram of iron for every drop of hemoglobin below normal volume. However, for iron sorbitol, the formula for calculating the dose includes by getting the deficit, which is subtracting the patient's hemoglobin from normal hemoglobin concentration, multiplied by body weight and multiplied by a factor of 3. Folic acid supplementation. Folic acid 5 milligram daily needs to be given to a patient that has folic acid deficiency as one of the cause of anemia in pregnancy, and one will continue this for at least 4 weeks, and the response to therapy is seen between 3 to 8 days from the reticulocyte count. Erythropoietin as one of the drugs used in the management of anemia in pregnancy, and the indication would be a patient that has chronic renal disease, end-stage renal disease, the Jehovah's Witnesses who will not take blood transfusion, iron deficiency anemia, and sickle cell anemia. And the dose is 50 to 500 international units per kilogram per week. And supplementation with iron too can also be added. And the route of administration is subcutaneously. For blood transfusion in the management of anemia in pregnancy, the indications are a patient that has severe anemia or heart failure, or when there is anemia coexisting with sepsis, hemorrhage, renal failure, hemoglobinopathies, or anemia in labor or during surgery. And for blood to be transfused, one need for chronic anemia, packed cells needs to be transfused. For acute anemia, for patient that has acute blood loss, whole blood could be transfused, and the transfusion duration for acute blood loss, for chronic blood loss, is between 4 to 6 hours, and one needs to follow the transfusion guide. Pre-transfusion vital signs need to be done for this patient, and the transfusion order needs to be written, and the transfusion protocol needs to be followed for the transfusion. For anemia in labor, danger of maternal mortality due to severe anemia increase sharply as soon as labor starts. Most maternal mortality due to severe anemia takes place during labor and 12 hours after delivery. And precipitate labor is commoner in patients with anemia in pregnancy because of intrauterine growth restriction. And anemia in labor, there could be high incidence of fetal distress because of underlying maternal TU hypoxia resulting from the anemia in pregnancy. And hemorrhage, they are poor, and this could result from operational delivery, or if they have general anesthesia. And fluid overload in them may lead to pulmonary edema. For transfusing patients during labor ward protocol needs to be followed, and this will include to reduce and correct blood promptly. Intermittent oxygen should be given to the patient. Prophylactic antibiotics also may be given to the patient, and assisted vaginal delivery electively by forceps to shorten the second stage by forceps or vacuum, and avoidance of episiotomy if there is no indication for episiotomy should be avoided. Then prompt repair of episiotomy and laceration if given, and active management of third stage needs to be done with parenteral oxytocin, and one needs to avoid ergometry. How is anemia in pregnancy is prevention? Prevention, they said, is better than cure. Prevention of anemia in pregnancy. Family planning can prevent maternal mortality and morbidity, and this will be by delaying motherhood or pregnancy to adulthood to prevent anemia. Discouragement of grand multiparity. Also, with family planning, there can be avoidance of closed spaced births. Also, preconceptional care is germane in the management of a patient with anemia in pregnancy. With preconceptional care, anemia can be corrected, and iron store also can be checked before the onset of pregnancy. Also, antenatal care also is very vital in the management, in the prevention of anemia in pregnancy, and this can be achieved through health education during antenatal care, and patients need to be counseled about taking their imatinics regularly, and also the need for them to have malaria prophylaxis by the use of intermittent preventive therapy for malaria, and also by the use of insecticide-treated nets for the prophylaxis prevention of malaria in pregnancy, thereby preventing anemia in pregnancy. Also, an intensive health education at the community level also can be used to prevent anemia in pregnancy, and this will include avoidance of early pregnancy, appropriate diet, especially during pregnancy, avoidance of bad cooking habits and food taboos. The society needs to know that bad cooking habits could lead to anemia in pregnancy, especially deficiency of folate. Fortification of staple foods with iron and folate. The public needs to know this, and also improvement of sanitation and improvement of the health facility also needs to be known. Also, African and other developing nations should aim at eradicating the triad of poverty, illiteracy, and ignorance. If these three can be tackled, anemia in pregnancy can be prevented in our environment. Prompt implementation of government policies on health too will go a long way in preventing anemia in pregnancy. In conclusion, anemia in pregnancy is still a major health challenge in many developing countries, with significant adverse effects on the mother and her unborn baby. It affects more than half of our pregnant women. The etiopathogenesis is multifactorial, and so management is by multidisciplinary. Prevention is the key to prevent its occurrence. Administration of hematinics and antimalarial prophylaxis are important in order to try to bring maternal hematocrit into optimal range for pregnancy. Pregnant women should be encouraged to book for antenatal care early to correct any anemia as gestational age increases. Thank you for listening.